Welcome everybody, and thank you for joining us with this midwinter Dementia Australia webinar. The topic for today's webinar is the de-escalation of severe responsive behaviours, or the de-escalation of emergency behavioural situations. It's a topic I think that we don't often talk about, so it's really wonderful to have a panel of absolute experts today to discuss their thoughts and their insights into this particular area. My name's Gary O'Toole, and I work for the Centre for Dementia Learning at Dementia Australia. I'd like to begin at the very outset just to acknowledge the traditional owners of the land on which we meet today, and I'd like to pay my respect to elders past and to future. Just a couple of quick housekeeping comments. We do have chat available, and we really encourage you, if you've got any questions, to pop your questions into the chat. We'll be monitoring those questions as we work through the webinar today, and we'll get a chance a couple of times, hopefully through the webinar this afternoon, to pose your questions to the panel. Just quickly introduce the panel. Karen Camille from Dementia Australia. Karen's been very involved as a facilitator and educator at Dementia Australia, but also in designing a number of our educational programs. Linda Kearton is a facility manager at St Vincent's Care Services in Hawthorn. Linda comes to us with an enormous amount of expertise and experience. And a very special welcome to Anne Fairhall, who's one of our dementia advocates at Dementia Australia. Unfortunately, Anne is phoning in today, so we won't be able to see her lovely face, but we will be able to hear her. I'd like to probably open up first and ask Anne. Anne, I know we've discussed this in the past, that your husband Jeff, diagnosed with dementia, was admitted to an aged care facility a number of years ago, and you have experienced quite a challenging time with him when he first moved into the aged care facility. I wonder if you can tell us a little bit about some of your experiences.
Thanks, Gary. Just confirming that you can hear me.
We can.
All right, good. Well, good morning to all those online for this webinar, and thank you for having me to speak about this today. Yes, my husband had a frontal temporal lobe dementia, and it was a younger onset dementia. I had him at home for about 20 years, and that was fairly tiring because there were a lot of severe dementia behaviours as part of that before he went into care. But about 13 years ago, and his whole journey has been over a 30-year period, about 13 years ago, I got sick, as often happens with carers, and had to put him into care. It actually was not what we planned, and it happened fairly suddenly. So we had no time to really prepare him for what was happening. Mm-hmm. As a result, he had quite a severe reaction, very severe reaction to going into care, and resisted that quite heavily. However, there was no alternative just at that time, because I could not continue caring for him. We expected that the carers and the nurses in the residential aged care facility would be trained and experienced to cope with these difficult behaviours, which I'd been dealing with at home. However, we were wrong, unfortunately. They did their best, but we found, sadly, and it made it more difficult, that they really didn't know how to handle those behaviours. As a result of the difficult behaviours, they actually exacerbated his behaviours over a period of time. And that was quite difficult. He reacted strongly to that. Gary, just one question. Would you like me just to go on with this story, or would you like to ask me any questions along the way?
No, I'd love for you to tell that story that we discussed last week, Anne.
Yeah, all right, okay. So I'll just keep going and be conscious of the time. Now, his behaviours became quite difficult, and as I said, they were exacerbated, and they were made worse by some of the things that the staff did, with to the best of their knowledge in an untrained way. And there were many things that triggered him. I actually was upset at the time about what was happening and asked, what was it that triggered this? And the staff, unfortunately, said, well, nothing. And I said, well, that's never the case. There are always triggers to severe and escalating behaviours, but they have to be worked out. They may be pain, toothache, headache, continence issues, hunger, thirst, etc. And maybe he's not understanding what's going on. He had severe cognitive issues and he was very deaf. So, and sometimes the triggers are just things like boredom and confusion and feeling lonely and scared. Many people will know about these things, but what you do about it at the time is not to ignore it. However, it was ignored and his behaviours became worse and worse. Now, because that was happening, they being all of us, decided that Jeff would move into a higher care dementia unit, not the general area. And again there, I stressed how important it was to make sure that that I had an opportunity to help ease his transfer into that area. However, unfortunately, they did not come back to me beforehand and just moved him. And he went into a very catastrophic behaviour. He just didn't understand what was going on. He became terrified, quite panicky, and very violently aggressive, terrifying the staff. And I could understand that. However, what they did was call the police, call the ambulance, and then after everything had escalated out of control, they called me. But they should have called me first, and as requested. However, it didn't happen. So we all learnt a lot about that, but we had to wait until there was a great escalation of his behaviour. So look, that's the story I wanted to just touch on, and then also to say, he actually had to be hospitalised, even though I was able to quite quickly de-escalate the situation. Other residents were locked in their rooms, paintings and other things were broken. It was very severe at the time and very frightening for the staff. So look, that's all I'll say at the moment, unless you want a little bit more information, Gary.
Look, thank you for sharing that story, Anne, and I can only imagine how distressing it was for you. But I really like what you said, that the impact of that emergency behaviour or emergency behavioural situation had on everybody involved, for your husband, obviously, for you, for the staff, for other residents, and I think that really pinpoints the real significance and importance of all staff within aged care environments having training and support to be able to feel confident to respond, I think, compassionately as well as skillfully to situations where behaviours do unfortunately escalate.
Yes, that's right, and I'm very keen to see more training done through the De-esc tool to help that training, because it was, the staff did what they thought was the best they could at the time, but it turned out that they didn't know enough at the time. So that will change. A lot has already changed, but thanks, Gary. I'll just be available if you need me more.
Thank you, Anne. Thank you for sharing that story. And thank you also for pre-shadowing a discussion we'll have a little bit later about a new program that's been launched just in the last couple of weeks from Dementia Australia, but I'll hold that back for a moment. I'd like now to introduce Karen Camille. Karen, as I said, is has for many years been a facilitator at Dementia Australia, but has also been involved in developing a number of the education and training programs at Dementia Australia. And Karen, what I thought I'd ask you is, I suppose, picking up some of the points that Anne mentioned about the triggers for changed behaviours or responsive behaviours in people with dementia generally. And we might talk a little bit more about those emergency behavioural situations a little bit later.
Sure, and good afternoon, everyone. Thanks, Gary, for that. We know that dementia it affects the brain. We know that the damage occurs throughout the brain with time. We know it starts in one part of the brain, but with time the damage we know travels to all parts of the brain. And we know how important the brain is in giving us that essential information that we need to function on that daily basis with all activities. And we know that due to those ongoing changes in the brain as the person progresses with their dementia, there's extra challenges and difficulties that arise, such as the communication, as Anne mentioned, understanding others, being understood, expressing and regulating emotions, thinking through, solving problems, memory issues, loss of independence and much more. And we all face stressful times and situations, no matter who we are. And for those living without dementia, we have the ability to think through and to problem solve and to reduce that stress and to make the situation better. However, for a person living with dementia, it's harder to express and communicate needs and to think through the problems and to problem solve, which leads to greater frustration, feeling overwhelmed, anxiousness and distress, which then can potentially lead to a changed behaviour. And as Anne mentioned so well, some of the main triggers that we see are not always to do with the fact the person has dementia, but often they're to do with the situation, how the stress plays out for the person if they're able to think through and solve those issues. So we know a lot of the triggers and causes that can lead to changed behaviours. As Anne mentioned, pain. Pain is probably the most common one that we see as a cause and a trigger to behaviours. We know for the person with dementia, it's hard for them to express or to explain their pain. They're not able to say, I've got a pain here, it comes and goes, it's sharp, and it's, you know, all those kind of ways to express it is very difficult for them. So often it goes unnoticed, underdiagnosed, under-assessed and under-managed. Another very common trigger that we see is how staff approach the person or communication, as Anne mentioned. Is the message clear? Are the words used by the staff helpful or unhelpful? Is there too many words being used at once? Do the staff members' body language and the tone match the message that they're trying to send with their words? Is the person being rushed, etc.? Overstimulation and sensory overload is also a very common trigger to change behaviours. For example, too much noise, lots of visual clutter, poor or too much lighting, unfamiliar environment, unfamiliar or overpowering smells, and so forth. You know, when all these sensory experiences are put together for the person, they can be overwhelming and they can lead to distress. Another common trigger and cause to some of these behaviours that we see is the person's history, their story, their past events that can also influence and contribute to behaviours. So, for example, perhaps a resident living in an aged care facility during the night goes around, opens all the doors, looks inside each room, waking other residents. However, when we get to know that person better, we find out that they worked as a security guard at night for many years, and their role was to make sure that the doors in the building were secure and locked. So in this case, the person is continuing with that previous routine and habits. So previous routines, habits, occupation, history, etc. can also be an influence and trigger or cause for behaviours. The environment, is it dementia friendly? Is there helpful signage, contrast and other supports that help the person to find that what they're looking for? Are there confusing patterns, shiny areas or dark areas that can be distressing and confusing for the person? So as we can see, often these triggers and causes to change behaviours are not necessarily only because the person has dementia, but on top of that, there are many other factors that we need to consider when we're looking at those triggers and causes and looking at understanding behaviours.
Thanks for that, Karen, and thank you for that really comprehensive description of some of the triggers that people can look for. And as Anne was saying, even with the best of all possible support for the person with dementia, sometimes we're unable to provide a way of of preventing those triggers occurring, and the resident's behaviour can escalate to the point where it becomes quite a concern and a behavioural emergency, in fact. I'm just wondering if you can describe for us a little bit about how staff and people supporting the person with dementia can effectively respond in those situations where the behaviour does become an emergency.
Sure. So first of all, let's talk about for the staff or for someone who's supporting the person living with dementia in these situations. So first of all, know what your organisation's escalation policy and procedure is. So be familiar with that. And if you're the person who's leading the de-escalation situation, or you're the first person there, think about yourself. How can you look after yourself to ready yourself to assist and support in this situation? So your body language, your tone of voice, think about the message that that's going to be sending. Ready your own physical and emotional response. And it is hard, it's challenging when faced with these things to think this way, but it is so helpful to ready yourself. Settle any excitement or anxiety you've got in yourself. You might do a couple of deep breaths to ready yourself. Be calm, open posture. Think about your body language, open palms. Stand to the side of the person to minimise size and maintain balance. And for the person's field of vision, so you can be seen but you're not too threatening. Use a low and a calm voice. And don't take it personally. It's important. Just need to safely manage the situation. So first of all, when faced with these emergency situations in terms of escalating behaviour, think about yourself and ready yourself. And then in terms of assisting the person living with dementia who may be part of this situation and displaying these behaviours, first of all, give them your full attention. Make sure that they feel that they're being heard by you and that their concerns are acknowledged. Minimise distractions. So what can we turn off? What can we move or get rid of if we can, or turn down, so that the focus is on communication? Communicate as clearly and simply as possible, straightforward, comforting language, speaking gently and slowly. Only one person communicating at the time rather than lots of people trying to assist, just one person doing the main communication. Practice our focused listening, pay close attention to what they're expressing, what's behind what they're expressing. Listen to key words to focus on a solution. Acknowledge their emotions. Validate their feelings. I can see this is upsetting. I can understand why you would feel angry about that. So that validation and acknowledgement of emotion is so important. Enter their reality. Try and perceive what the world is looking like for them. Understand potentially the cause of their distress. Show genuine concern. Demonstrate you're committed to understanding and addressing this, and build that sense of trust. Build rapport and trust. Establish a trust relationship through genuine interaction. Be honest. Don't make promises that you don't intend to keep. Maintain respect, acknowledging their identity and what matters to them. And a lot of this, of course, is knowing the person. So we do know for them how to build rapport, that we do know what is important to them. Check your understanding. So using that reflective listening. Work in partnership. So how can I help you? What would you like to happen here? So making sure that you're part of that partnership, that relationship, to work towards a solution. Use positive gestures and sounds, and allow flexibility. So we know that safety overrides process and procedures in this instance. So being flexible in how you can assist and working towards that. Now, in terms of setting up the environment in order to assist when we do see these escalation or this emergency situation. So first of all, scan the environment. So think about, where are the exits? Try not to trap the person or be trapped yourself, of course. You need to know where the exits are for a quick access if you need it, to remove yourself for safety, but also not to trap the person as well. Check for potential weapons. We know that there's many items in an environment that might be utilised as weapons. So think about quickly removing those in the event of something like this, an emergency. Check for others that might be at risk or involved. How can we potentially safely remove them from the situation too? Ensure it's well lit. Make sure the lighting is good so everyone can see what's happening, not too bright, but enough for us to see what's going on, who's involved. Minimise noise and distraction. Check levels of stimulation. As I said, turn down things, turn off things if you can that aren't helpful. It's also important to maximise the person's understanding of the environment. Make sure they can see you. So that's where your lighting and your environment plays a big part, that you can easily be seen. Allow space. If the person is in a heightened state or in an emergency situation, make sure you give them space. Don't overcrowd them. Maintain that safe distance of at least an arm's length or standing to the side, as we mentioned before, so you're not threatening. Don't gather around. You know, there's nothing worse than 10 staff on this side, one person there, feeling like you're overcrowding them. Give them enough space so they don't feel trapped or threatened. So there's some basics, I guess, that we can use when we're confronted with these situations. So first of all, ready yourself. Think about the environment, scan it, understand it, allow space, and then how we interact with the person. They're so important. It's just some basics there.
Thanks for sharing those, Karen. Some really, really practical, useful ideas. A follow-up question. One of the things that really jumped out for me when we did some of the de-escalation training at Dementia Australia was, and I should have known this, but it just really jumped out at me, was that as well as the resident, the person living with dementia, moving through an escalation cycle sometimes, that the support worker is also likely to be triggered through an escalation cycle themselves. So particularly if the person with dementia is presenting in a threatening way, they're verbally or physically aggressive, that triggers all of my alarm bells. And we have that sort of terrible situation where both the worker, the support worker, and the person with dementia are being pushed through an escalation cycle. I'm just wondering if you've got any comments about that.
Yeah, that is an excellent point, and that's the beauty of this program, this workshop, is we do explore the de-escalation or the escalation cycle and then de-escalating, so that exploring that cycle, but also not just how it affects the person, like you say, Gary, but for us as staff, how we're affected through that, because it does impact, doesn't it? You know yourself, if you've had a situation where you felt threatened or you've felt hurt for various ways, it does affect how you support the person. You know, do you want to go back the next day and support them when you feel threatened or you're scared or you're hurt? And it does impact, and rightly so. And I think most of us, if we've worked in aged care, do have that experience. So it is important, and as part of this workshop, to explore not only from the person's point of view, but for us, you know, what supports are there for us as the staff.
There's an escalation cycle going on in the background.
I do apologise.
Karen, I might move on to a question from the audience while you're dealing with the escalation cycle in the background. Kylie, you've been monitoring the questions from the participants. Has anything really jumped out at you from the chat?
Yes, thank you, Gary. We have got a question here. You mentioned about being mindful of exits. Some spaces in our facilities don't have dual exits, so staff may find themselves with a person living with dementia in a heightened state, positioned blocking the exit for the staff or others. Any advice in that instance?
I'll throw that open both to Karen and to Linda. We haven't introduced formally Linda. Linda from St Vincent's Care. Any comments about that situation where exits can be a little difficult to find, perhaps? Linda.
Yeah, look, it's unfortunately not an uncommon situation, particularly, I guess, when you may be entering a resident's room and generally there's only one entrance and exit in that situation. And it's generally also quite an enclosed kind of compact space. So I think perhaps being mindful at all times when you're entering into a space in anticipation of perhaps some kind of behavioural emergency or any kind of crisis, whether that be a medical crisis or anything like that. Just doing a very quick mental assessment when you enter the room as to where that person is, where you are in relation to them and the exit, and also perhaps noting any other area in the room that could potentially be somewhere where you could move into, or perhaps a resident's bathroom, for example, something of that nature, just to have that mental checklist in your head. Having said that, with the very busy routines and things in a residential environment, being that aware and mindful can be challenging at times. But I think it's really necessary for staff safety as well as the best management of those kinds of situations.
Thanks, Linda. And it's interesting, isn't it? We don't want staff to become hyper alert. These incidences of behavioural emergencies are quite rare, and particularly with good support and effective support for the person living with dementia, we fortunately don't see these incidents, sorry, all that often. I remember many years ago when I first started work as a community nurse, so working in people's homes, it was one of the first things that was always instructed, that we should always just be aware of where the exits were and where you were in relationship to the exits, again, without being excessively cautious, but just in the background. I like that idea of being mindful. It's not something that's you're fully aware of. It's just something in the back of your mind at all times. Thanks for that, Linda. I don't know, Karen, if you wanted to make any other comments on that point.
Yeah, I think you've covered that very well in terms of that not being too stressed in your environment. That's going to happen. When's it going to happen? Am I going to be ready?
Yeah.
And the whole thing is understanding the people that you're supporting, that you know them well enough that you're, I guess, a little aware when there is distress or something's different, that at that point, you know, we step in and we assist so we don't get to that point of seeing these kind of emergencies. So I think you've covered that really well, but also that support, and I do apologise for the barking of my dogs. Sorry about that. But certainly knowing your supports as well for yourself is so important, and how you, when you do encounter these situations, you know, you making use of your EAP or your counselling systems at your work and things like that are important. And just yeah, not to be worried, but just to do your best to feel equipped. And that's where I guess the training is so important, that you feel, if it does happen, you do feel that you have tools in your belt that you can use at that time as it's needed. Yeah.
Absolutely, thank you. Kylie, I think we might have time for one more question if there's another one.
Yes, of course, Gary. There's actually there's a somebody here's asked something of Anne, about Anne's with her husband.
Mm-hmm.
Oh, I'm sorry, I've just lost it now.
Okay.
They asked,
it's just
it
like
was
live radio.
Yeah, interested to hear what were the behaviours Anne's husband had, and what her de-escalation strategies, which the staff did not use.
Anne, are you able to unmute? We might hold that question. Oh, there she is.
Oh, have I unmuted now?
You have indeed, Anne.
Oh, good. Okay. Well, thank you for that other question. Yes. Look, the difficulties. As I was listening to Karen and also Linda there, one of the things that Jeff, my husband Jeff, reacted very quickly to is body language. So if someone looked fearful or aggressive, in his view anyway, he would become more difficult. And so one of the things that was really important that I had to convey to the staff to get, while they got to know his needs, is to not look fearful. That is, don't move quickly. Don't look as though you're fearful about the situation. And I never was. So I always opened up by saying, "Oh, what's happening here?" and put it back to him. And that usually distracted him a bit, and so on. But many of the staff who were young, perhaps quite small, he was a big man, they felt intimidated by him, just his size, not necessarily anything he actually did. But that was one thing that I certainly found was very useful. Always to come back to him, knowing who he was and what he was. He was always a leader. He was a senior executive. He was in charge of people. And so he always wanted to be in charge of fixing a problem, whatever that may be. And many of the escalations happened when he was not given the chance to be part of the solution. That's one thing. And the other is the body language, which I heard mentioned before too. So they were a couple of key ones. But also the other one, which is very important, is communication. And I had this thing in his room which just said, simple, slow, stop. And that all communications needed to be like that. So it needed to be very simple. If it was a question, he couldn't answer. He could answer yes or no to, but he couldn't answer it if it was more complex with cognitive impairment that he had and the deafness. So the communication was very important. The body language was exceptionally important. He would see someone and say, "I don't like that person," or "that person's not happy," and he would say it very loudly, which upset them. So my de-escalation was to try and put it back to him to be part of the solution and feel he was part of the communication, and never to show fear, never to show resistance, trying to make him do something they wanted him to do. He got very trapped, feelings of trapping or entrapment. Yeah, but that's probably the main thing. So communication, being part of the thing, asking him what's happening, and then also other specific things, knowing the person.
Thanks, Anne. So some really simple and easy to implement strategies. And it was interesting while you were talking about the not looking fearful, and the first thing that popped into my mind was the real danger when residents or people living with dementia are labelled. When staff, you hear in the tea room or at handover that Gary's, be careful of Gary, he's aggressive, and we are already sort of preset when we come into Gary's room, and we're communicating in that very subtle non-verbal way a whole lot of information that can be a real trigger for many people, I think.
Absolutely right. And there's one other thing that we haven't mentioned today, and that is one of the problems was that they were trying to use medication to calm down, not de-escalation of things, or not. And of course, that just made there to be another complex issue, which was related to the medications. But they didn't want to take him back. But I said, after you've been in hospital. So, but he was already demedicated by then. Very calm.
Yeah. Well, that's a topic for a whole other webinar, isn't it? The use of antipsychotic and psychotropic medication. But we won't go there today, perhaps.
No.
Thanks, Anne. Look, just quickly back to Karen. We've sort of been hinting all the way through the webinar about a new program developed at Dementia Australia, a really exciting program using virtual reality called De-escalation, which runs through very practical advice and support for staff who are finding themselves in this situation. I'm just wondering if you can spend a couple of minutes just describing the contents of the program, how it was developed, and some of the unique features of the program.
Sure, yes, be more than happy to talk about that. Yes, it is very exciting new program. So De-escalation, obviously short for de-escalation, a new virtual reality workshop which shows care staff how to safely de-escalate high-risk behaviour in people with dementia. So it is based on the scenario and the simulation that the participants do when they do this course is based on a realistic emergency. So one that is quite common, one that you would come across often in aged care. So it is one that's very relatable for staff. And the wonderful thing about this program is that it offers a safe and controlled simulated environment where you can practice de-escalation skills. So it's safe because if you get it wrong, you're not hurting, obviously not a real life situation, not hurting the person or yourself. So it's a good chance to practice skills in this area and staff can see the outcomes of their decision in real time. So some of the benefits of and learning outcomes for this workshop include participants or staff who do this course recognise emotional and physical signs of escalation in behaviour, build staff confidence, capabilities and skills to assess and to respond when faced with a behavioural emergency. The staff learn how to apply person-centred de-escalation skills. Another benefit or learning outcome is that staff learn how to contribute to debriefing to determine potential causes of the changed behaviours and also reduces the risk of harm for the person living with dementia, but also staff and also others, because we know many are involved when these situations happen. Now, in terms of what it looks like, or in terms of its unique features for this particular workshop, it uses virtual reality goggles, which you may have used, these headsets, to experience a real life simulation and a common, as I said, a common and realistic behavioural emergency. Now, once you're in the simulation using your headsets and your goggles, you will become the onlooker to see this behavioural emergency taking place. So it's similar to a choose your own adventure style, where during the simulation, it will stop and the staff member who is in the simulation will turn to you and give you some choices, and you'll be given these choices and you'll have to decide which choice to make. So at this point, do I do this? These are the situations, this is the situation, these are the options for you. So you choose yourself what path you're going to take, what choice you're going to make. And depending what you choose at that time where you're faced with this decision, you will see the outcomes played out in real time. So it will continue through the scenario and you'll see what will happen as a result of the choice you make. And then you'll choose another option and it will stop. It'll give you another choice to make. Do I do this? Do I do that? Which one will you choose? And again, the situation, the outcome will take place in real time, both the positive and the negatives based on what you choose. So it's exciting because it's a choose your own adventure. You make the choices and then you see the outcomes in this situation. And during the workshop, we unpack the simulation and the choices that were made to see the result of the choice and talk about the outcomes and why it happened. There's also videos to explore, highlighting the positive and the negative choices or experiences that are played out. So all staff are able to see all outcomes, no matter what you choose, whatever path you take, you can still see the outcomes. And there's also a case study that runs through the whole workshop that we look at, which is based on the simulation and the person in the simulation. So it's very powerful, very practical in nature, and ensures the translation of knowledge into everyday practice and roles. So it is exciting in that it has that unique feature of that choose your own adventure. Thanks, Gary.
Thanks, Karen. It is an exciting program without sort of trying to push it on the audience. I've had the opportunity to deliver the program a couple of times now, and it was just very interesting. At the beginning of both sessions that I facilitated, I asked the group whether they had had any de-escalation training in the past, because I know that it's very common with healthcare workers in a whole range of other settings, in community work, in acute care, in the big hospitals. And I was really surprised that nobody in either of the two groups that I facilitated had any de-escalation training. And it's not just residents, and it's not just residents with dementia who perhaps can present an emergency situation. We are dealing with stressed and tired and angry and guilty families and visitors sometimes. So I was just very surprised at how little emphasis we have had in aged care, and particularly with some of the sort of key events over the last couple of years in other states, perhaps. Yes, just surprised me. Just on that point, I might move to Linda Kearton, who's the facility manager at St Vincent's in Care in Hawthorn. Linda, just wonder if you could share some of your experiences with supporting staff and families and people living with dementia experiencing some of these behavioural emergencies.
Yeah, thank you, Gary. I think to follow on from your comments about the fact that there are very few staff in aged care who've had the opportunity to receive any kind of practical or formal training in regards to de-escalating situations. Even as an aged care arm of St Vincent's, which has public and private hospitals, I'm aware that they have some programs in the hospitals to manage and de-escalate certain emergency situations and crises. They also have the addition, of course, of dedicated staffing, security staff and things to assist them in those situations, which we don't have in aged care. But, you know, de-esc, where have you been all our lives? You know, it's just so important and so timely for our teams, so that they feel confident, that they feel safe, that they feel supported, and that they have the tools that they need to be able to support these people. It's important for the residents, naturally, that they are understood at a better level, that they are supported, and that the outcomes or the behaviours that are being displayed aren't necessarily, or most likely not as a result of them living with dementia, but they are in many instances, avoidable outcomes that if we understood the triggers better, if we understood the individual better, if we could recognise when things were perhaps the wheels were starting to fall off for that person, and intervene at that point, that we may not need to rely on having to de-escalate an inflamed situation. So, you know, it starts really in the training of the care staff and the nursing staff. In the Certificate 3 and 4 courses, the amount of time spent on educating future carers on understanding dementia and understanding these kinds of situations and how to respond is minimal at best. The amount of time in those courses dedicated to that is really inadequate. So this is where we need to step in. Unfortunately, once they're qualified and come into our homes, that's the time where we need to respond, I think, and this is a perfect opportunity to do that.
Absolutely, Linda. And one of the things I really loved about the de-escalation program was that we're not jettisoning all of those person-centred principles that we use to support people living with dementia. That knowing who the person is, knowing what they're proud of, and what motivates them, who they are as a person, is still an absolutely key part of the process of de-escalating these situations. As Karen said earlier, validating where somebody is emotionally. It may not be the same reality that you or I are experiencing at the moment, but it is true for that person, knowing enough about them to be able to make that personal connection, even in that escalating cycle of emotion and neurotransmitters and all of that stuff that's going on for the person living with dementia, that we still utilize all of those skills. Linda, I'm just wondering, you've had some of the education at some of the St Vincent's facilities. I'm just wondering how they were received by staff and if you'd noticed any differences in the way staff are utilising those skills.
Oh, absolutely. We were really fortunate to be able to trial two different homes, the DS program. So firstly, I guess, and I also was able to participate in one of those sessions and personally experience the program as well, which was great because then I could relate to what the staff's feedback was in a better way. So I guess some of the things that came about as a result of them participating in this program was it sparked a lot of conversations. So when the program finished and we had gone through all of the elements of the program, the conversations didn't stop. It sparked an interest and a curiosity. It facilitated the staff to be looking at particular residents and discussing how this particular scenario may have related to something that they've experienced with a particular resident or some of the strategies. So I think what was great was as Karen was saying, you've got the opportunity in real time to be able to make decisions in a safe environment. And even though there is a time frame, you do need to respond in a reasonable time frame. So you don't have the luxury of sitting there for half an hour and ponder and Google and talk about things. You really do need to respond in a timely manner. And for me, when we were debriefing after the first initial scenario where the participants had made different choices in many cases and that took them down different pathways, and then talking afterwards about, well, who chose this and tell us what happened in that situation for the people who didn't make those choices, to then be able to compare what the different outcomes were was really helpful. And there were a couple of participants and you could almost see that light bulb turning on. It was almost that visceral. You talking through, well, this person chose that and I chose this, and this is what happened in the scenario as a result of my decision. And then hearing what somebody else has done and what the outcome may have been for them, and talking through why, what was the difference, and understanding it. And honestly, you honestly can see that the penny drop, and that's priceless. I think it's so valuable.
Absolutely. And just for people watching or listening in today, I believe we've posted some information about that program in the chat. So if you're interested, you can follow up. Kylie, I'm just wondering, I'll throw it back to you. I'm just wondering if there have been any further questions that have popped up in chat.
Yes, Gary, we have had quite a few questions coming through. And you've just covered, a lot of people are asking where they can access this information. So that's been put into the chat. Also, we've got, there was a patient with BPSD symptoms seem to be more prevalent. This person works in a gem ward in an acute hospital, and we're getting many more patients admitted now because facilities are unable to manage the behaviours of concern.
Thanks, Kylie. Without not wanting to be part of the dementia police, but one of the things that we're really keen on at Dementia Australia is the impact of language. And again, not criticising the questioner, because it's a really important question and something I think that's happening a lot. But we tend to avoid BPSDs as a description unless we're talking about a research project. BPSD being behavioural and psychological symptoms of dementia. Responsive behaviours or change behaviours, I think, is a much more useful way of talking about them. But I'm going to get off my soapbox and throw to Linda and Karen if they've got any comments about that situation.
Well, firstly, I think because the government is trying to support people to stay in their homes for longer, it's a natural, the natural result is that we're going to be seeing people coming into care in a much more advanced state of their healthcare journey, whether that be living with dementia or any other condition. And with the known lack of training for staff to be able to recognise and respond to these types of situations without us delving into that even deeper, it's an unfortunate thing that when they can't manage it, the knee-bone reaction or the knee-jerk reaction is to then send them somewhere where they feel that they're going to be better responded to. Unfortunately, though, we know that putting somebody who is already confused, agitated, overwhelmed, taking them away from an environment where they may be more familiar and putting them into a hospital, for example, particularly in an emergency ward or something of that nature, is going to do anything but support them at that time. And so I fully understand the concerns of the person who raised that question, that they're now in receipt of somebody who is in a behavioural emergency, and where if the staff had the tools that perhaps De-esc or some of the other programs can offer, if they'd had those tools, it may not have got to that stage, and that's obviously where we need to be looking to head. It's
interesting that the needs for education, skill, training, confidence is sector-wide, isn't it? It's across the whole healthcare sector, not just a residential aged care or a community sector. Karen, did you have any further comments?
Oh, I think Linda covered it very well. Yeah, I mean, you see it the other way, where a person is admitted to hospital maybe for a medical reason, and then once they're admitted back to where they came from, often they do sometimes those behaviours that are displayed in hospital, they get back to their facility where they've come from, and then they do tend to settle too when they're back in that environment. So it goes both ways as well, I think, as well. And I think, like you said, Gary, it is sector wide, and these skills are helpful no matter where someone is working. And I think there are extra challenges that come with different settings, but these skills, I think, are universal and will be very much adaptable no matter what the sector. But the luxury of being in aged care facility is that you have time to get to know a person. Yeah. Obviously, that time in a hospital, there's in acute care setting, there's not much time to get to know them, is there? And they're there because often they're unwell. There's a reason for them being there, or underlying things. But it is certainly does come with an extra set of challenges with the environment and the not having that luxury of time that one does get often in an aged care facility. So all those things, I think, do add, depending on the environment, do add to the potential for the behaviours as well. But I think you said it really nicely, Linda. Yeah. So.
Thank you. And if I can quote the wonderful Anne Fairhall, if we can get it right for people living with dementia, we get it right for everyone.
Absolutely. It's such an important message, isn't it? That dementia is not some tiny specialised area that has no relationship to anything else, but person-centred care is something that we say sometimes at Dementia Australia. If you're not in a person-centred organisation, how can you be expected to provide person-centred care? It's something that affects everything we do, the way we interact with other staff members, with our colleagues, with people living with dementia, with their friends and families. Kylie, another question. I'll take the risk.
Sorry.
In terms of time.
With this simulation, how would one know if their response to their situation is right or wrong? Because every resident will respond differently to different actions and words. Does it consider cultural beliefs?
Over to you, Karen. Big question.
Yes. Excellent question. That is a terrific question. And that's the beauty of the workshop, is that you've got time to unpack it. You can unpack all those things. You can talk about all those things. You can also go back into the simulation and do the other choices that you didn't make, and you can explore those. You can see what that looked like. So you do get a chance to see all of the outcomes, depending what you chose. Even if you didn't choose one, you can go back in and choose it and see what happens. So we also have it's 3-hour program, so we have the time to be able to explore what happens in all of those outcomes, so we can all see them and we can all see the outcome and we can unpack them. We have time to explore them when we look at not only the de-escalation cycle, but when we also talk about the case study as well, and some of the issues there. And certainly we do talk about cultural differences and background and the influence that can have, and how we can tailor our strategies to be person-centred, so it doesn't matter what that person's preferences are or background, whatever. So because it's time, got good time to be able to unpack all those things. Absolutely. Great question.
Thank you. Kylie, well, I'm going to really push it. Can we have another question, please, from the audience?
Yes, of course, Gary. With the issue with some residents living with dementia is that the changed behaviours are not fully disclosed at the time of admission, and then after escalated behaviours due to new environment, etc., encourages family and other professionals to disclose the full extent and other diagnoses that may not have been listed. This may be due to desperation for finding the beds.
Yeah.
Sorry, that wasn't really a question.
Interesting comment, though, I think. And, you know, I was thinking this earlier. I think one of the things, one of the shifts that needs to happen is that to see responsive behaviours, even behavioural emergencies, as forms of communication rather than symptoms of dementia. Obviously, the changes in the brain associated with dementia are really important in terms of being the underlying cause, perhaps, of changes in behaviour. But if we can ask ourselves, what is this person with dementia trying to communicate, trying to tell me? As Karen said, are they in pain? Are they lonely? Are they confused? Are they lost? Are they overstimulated? It really changes, for me anyway, my perspective on how I, quote unquote, manage a behaviour. It's not just an expression of the dementia, but a form of the person with dementia communicating something to us. Again, really quickly, I'm not sure if Karen or Linda have any comments, or Anne for that, any comments about that?
I would, yeah, sure. Look, I do understand where this person is coming from, and I think anybody who works in residential aged care will have had a situation like that before. And I agree, sometimes I think it is out of desperation, whether it be on the part of the family trying to find somewhere to place their loved one. And I think of a recent example that we had in our home. A gentleman came into our care with very little information offered about his situation. It was all very rushed, and he came in to live with us on respite. We found out in the course of the next few days that he had actually, this was the 4th residential aged care home that he had been placed in, and I remember thinking to myself, that poor person, that poor man, how difficult must this be for him, having to learn a new environment, try and make sense of where he is, who these people are again, etc. And it was really no great surprise to me that that came out, that he expressed that feeling of being so confused and discombobulated in his behaviour and in the way he responded. But I think if we can, as Gary said, see this as a form of communication, and if we can see this as an opportunity to be able to one, help our staff and our teams learn how to understand the situation, understand this person, get to know them and their families and their backgrounds, and then put some strategies together as a team and in a supportive kind of way. And when I say team, I'm not just talking about the paid staff members, I'm talking about family members and those who support that individual, and really come up with some strategies and some ideas that can be trialled. I think it's an opportunity that we have, and I think it's one that you know, with the right training for the staff, whether it be de-esc or anything else of that nature, that we have a responsibility to really embrace that and take it on.
Thank you, Linda. And I think that's a wonderful positive note to end the webinar on, that we have an opportunity to know people, to support them, to understand what motivates their behaviour. So thank you all. Look, I'm aware that it's just on 2 o'clock. We could spend the rest of the afternoon talking about some of these topics and some of the other ideas that have popped up during our discussion. But look, I'd really like to thank Anne and Karen and Linda for your time and your insights into this particularly sometimes challenging topic. Also, the people in the background who have been pushing all the buttons and making sure everything went well. To Vicky and to Jim and to Kylie, thank you very much for your support, and certainly thank you to our wonderful audience and for the questions that you've placed in the chat, and hopefully we've had an opportunity to answer some of those questions. We really look forward to seeing you at our next webinar, which is in August, June, July, August, yes, and we'll be sending out information about that. A recording of this particular webinar will be made available on our website, and we'll let you know as soon as possible. Thank you all. Enjoy the rest of your afternoons.